Appearance. 1. Is the patient dressed appropriately for age, weather, occasion, and social norms? 2. Is the patient's makeup or application of toiletries appropriate? 3. Is the patient's hair cleaned, neat, and appropriately styled? 4. Is the patient clean? 5. Posture. 6. Presence or absences of physical disabilities. 7. Words use: attire disheveled, showered and grooming, wearing clean clothes. Bizarre, inappropriate. Behaviors and motor activities. 1. Note the patient's body language. 2. Describe behavior and level of activity: restless, agitated, lethargic, psychomotor retardation, tremulous, appropriate. 3. What is the patient's behavior toward you? Cooperative, uncooperative, friendly, hostile, suspicious, belligerent. 4. Abnormal movements: hyperactive, bizarre gestures, mannerisms, tics, tremors, restlessness, akathisia, repetitive behavior, dystonia, catatonic feature, orobuccal dyskinetic movements. 5. Gait and coordination. Speech. 1. Quantity: normal amount, voluminous, poverty of content, very superficial, or poverty of speech. 2. Quality: clear, pressured, slurred, monotone, dramatic, whispered, tremulous. 3. Rate: slow, normal, or rapid. Mood and effect: how are you feeling today? How does it differ from yesterday? 1. Mood subjective: sad, happy, fearful, anxious, angry, depressed. 2. Mood objective: elated, dysthymic, euthymic, apathetic, blunted, irritable, anxious. 3. Effect. A. Facial expressions, vocal fluctuations, gestures. B. Broad effect: ability to express a full range of emotion. C. Blunt effect: ability to express emotion but it is stifled or blunted. D. Flat effect: inability to express emotion. E. Restricted effect: one type of expression. F. Important to note: congruent or incongruent with mood or situation. What looks like plus congruent equals the same. Incongruent appearance didn't match the statement. Thought process. 1. Logical. 2. Coherent. 3. Goal-directed. 4. Circumstantial: provides excessive and unnecessary details before getting to the point or answering a question, eventually returning to the original topic. 5. Illogical. 6. Tangential: veers off topic and doesn't return to the original point. 7. Flight of ideas: rapid, continuous shifts between loosely related thoughts and ideas. 8. Looseness of association: a lack of logical connection between ideas. It's characterized by a shift from one topic to another with little to no apparent connection between them. Sentence doesn't make sense. 9. Word salad: a severe form of disorganized thinking where an individual strings together words in a way that is incoherent and lacks meaning. 10. Neologism: coining new words spontaneously. 11. Concrete thinking include believing that when someone says the meeting will be a piece of cake, they mean that dessert will be served, or they may think someone saying, "I'll be done in a sec," means that they'll literally be done in a second. Thought content/perception. What is the central theme? Does the point hallucinate? Hear sounds or voices that nobody else hears? Does the point have delusions? What type? 1. Ideas of reference are a belief that everything one perceives in the world relates to their own destiny, usually in a negative or hostile way. Believe some normal things happen related to them. 2. Thought broadcasting: believe their thoughts can be perceived by others. 3. Thought insertion: believing thoughts are being controlled by aliens or other external agents, or feeling a loss of ownership over one's thoughts, as if they belong to someone else. 4. Thought withdrawal: believing that government agents or some other entity is stealing one's thoughts, leaving the person with a feeling of memory loss or inability to articulate their thoughts. 5. Jealous, stalking and other obsessive behaviors, being convinced of someone's infidelity despite having no evidence, constantly checking and monitoring their partner's social media, blaming them for problems, and attempting to isolate them from friends and family. 6. Somatic, false, fixed beliefs about one's own body or bodily functions. Like feel themselves sick, infected, part of body loses. 7. Religious, may feel sure that a religious figure or deity is speaking to them or that they themselves embody a religious figure. 8. Grandiose, false beliefs about one's own importance, power, or abilities that are not based on reality. 9. Persecutory, an individual firmly believes they are being mistreated, harassed, or harmed by others, even when there's no evidence to support this belief. 10. Erotomania is delusions are a type of delusional disorder where the individual believes that another person, usually a celebrity or someone of higher social status, is in love with them. Obsessions, fear of contamination, intrusive thoughts, and a need for order. Rituals is individuals may engage in repetitive acts stemming from a fixed, false belief. For example, a person with a delusion that their home is haunted might compulsively clean every surface to ensure the presence is not detected. Phobias. Phobias are intense, irrational fears, while delusions are false beliefs that are not based on reality. Examples of phobias include fear of flying, spiders, or heights. Suicidal ideation, SI. Ideation, plan, method, access, where, when, timing. Homicidal ideation, describe plan. 1. What thoughts have you had about hurting? 2. What is your plan? 3. What do you want to do to? 4. Duty to warn and duty to protect. Paranoid delusion. Paranoid delusions are characterized by persistent, false beliefs about being targeted, persecuted, or manipulated by others, often involving government agencies or specific groups. Condition and orientation. Orientation plus remote and recent memory. Insight and judgment. 1. Insight. How well does the patient appraise her symptoms and situation? 2. Judgment. How well does the patient take responsibility for actions, understands consequences of behavior, or make rational decisions? Suicide intervention. 1. Contraband. 2. SSSI plan, means, intent, Q shift and PRN. 3. Body check. 4. Observation Q 15 minute. 1:1 mean 1 sitter, 2:1 means 2 sitters. 5. Medication. 5. Encourage point to express feelings. 7. Safety plan, identify trigger, stressor, warning sign. Ask most important thing worth for living. Ask environment safety. Gun, weapon. 8. Provide safe milieu. NSSIB, non-self-suicidal injure behavior. Intent, the action they did before may kill most people considered intent. Intensive seeker behavior doesn't equal to suicidal behavior. Empathy definition, the capacity to understand or experience the feelings of another person. Sympathy, assume, it's hard huh? Someone kicked out of school, at least the other kid is good. Typical antipsychotic or first-generation antipsychotic FGA. Haloperidol, Haldol. Chlorpromazine, Thorazine. Flufenazine, Prolixin. 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 Haloperidol, Haldol. Chlorpromazine, Thorazine. fluphenazine, prolixin. Haloperidol, haldol. Chlorpromazine, thorazine. Fluphenazine, prolixin. Haloperidol, haldol. Chlorpromazine, thorazine. Fluphenazine, prolixin. Block dopamine and improve positive symptoms. No haldol plus Benadryl in same syringe can cause precipitate. Haloperidol, haldol, and fluphenazine, prolixin, side effect include extrapyramidal side effects and tardive dyskinesia and higher risk of EPSE because of its high potency. Chlorpromazine, thorazine, side effect include anticholinergic side effects, sedation, orthostatic hypotension, low-risk EPSE. Atypical antipsychotic. Second-generation antipsychotic SGA. Olanzapine, Zyprexa. Risperidone, Risperdal. Ziprasidone, Geodon. Quetiapine, Seroquel. Clozapine, Clozaril. Olanzapine, Zyprexa. Risperidone, Risperdal. Ziprasidone, Geodon. Quetiapine, Seroquel. Clozapine, Clozaril. Olanzapine, Zyprexa. Risperidone, Risperdal. Ziprasidone, Geodon. Quetiapine, Seroquel. Clozapine, Clozaril. Olanzapine, Zyprexa. Risperidone, Risperdal. Ziprasidone, Geodon. Quetiapine, Seroquel. Clozapine, Clozaril. Olanzapine, Zyprexa. Risperidone, Risperdal. Ziprasidone, Geodon. Quetiapine, Seroquel. Clozapine, Clozaril. Olanzapine, Zyprexa. Risperidone, Risperdal. Ziprasidone, Geodon. Quetiapine, Seroquel. Clozapine, Clozaril. Olanzapine, Zyprexa. Risperidone, Risperdal. Ziprasidone, Geodon. Quetiapine, Seroquel. Clozapine, Clozaril. Olanzapine, Zyprexa. Risperidone, Risperdal. Ziprasidone, Geodon. Quetiapine, Seroquel. Clozapine, Clozaril. Block dopamine and serotonin. Improve positive, negative and mood symptoms. Common side effects include less EPSE/TD. Metabolic side effects which include weight gain, increase in blood sugar, increase in lipids, fats, increase in blood pressure, low-risk EPSE. Risperidone, Risperdal, is the only atypical antipsychotic medication has high risk of EPSE. Ziprasidone, Geodon, is the only atypical antipsychotic medication has low risk of metabolic syndrome. Clozapine, Clozaril, is the only one reserved for patients with treatment-resistant schizophrenia, beneficial in suicidal ideation and EPSE. Must restart dose titration if greater than 48 hours since last dose. Abrupt discontinue can lead to cholinergic rebound and acute psychosis. REMS, risk evaluation and mitigation strategy, for severe neutropenia. Benzodiazepines. Lorazepam, Ativan. Alprazolam, Xanax. Clonazepam, Klonopin. Benzodiazepines. Lorazepam, Ativan. Alprazolam, Xanax. Clonazepam, Klonopin. Benzodiazepines. Lorazepam, Ativan. Alprazolam, Xanax. Clonazepam, Klonopin. These drugs bind to specific receptors next to the GABA receptors, thereby enhancing, potentiating, the action of GABA. Used for PD, GAD, social phobia, more effective in treating psychological and cognitive symptoms, excessive worry. No abuse potential. More effective for somatic symptoms and for anticipatory fear/avoidant behavior. Onset of action, 1 to 2 weeks, sooner for acute anxiety. High dose of BDZ for long-term, risk of tolerance, abuse potential and withdrawal if stopped abruptly. Fatal when combined with opiates. Need to withdraw slowly, taper down doses, to prevent seizures. Good, quick onset. Bad, habit-forming, sedating. Side effects include sedation, ataxia, anterograde amnesia, cognitive impairment, respiratory depression, paradoxical excitation, dementia. Patient teaching include withdrawal symptoms, anxiety, insomnia, muscle tension, seizure. Don't mix with alcohol. What kind of symptoms does typical antipsychotic treat? Positive symptoms only. What kind of symptoms does atypical antipsychotic treat? Both positive and negative symptoms. EPSE happened because of dopamine was too low, acetylcholine too high. To decrease the acetylcholine, Benadryl, Cogentin, Ativan. EPSE include hours to days, acute dystonic reaction. Day to weeks, akathisia. Weeks to months, pseudo-Parkinsonism. Month to years, tardive dyskinesia, non-reversible. Acute dystonic reaction. Painful muscle spasm of eyes, face, neck, back, throat. Oculogeric crisis, eyeball go back can't come back. Torticollis, head go to a side can't come back. Relief of acute dystonic reaction. Cogentin, benztropine. Benadryl, diphenhydramine. Artane, trihexyphenidyl. Ativan, lorazepam. Akathisia, pacing, restless, inability to sit still, restless, get worse after start antipsychotic. Relief of akathisia, propranolol. Pseudo-Parkinsonism, rigidity, akinesia, slow movement, tremor, mask-like face, loss of spontaneous movements. Relief of pseudo-Parkinsonism, Benadryl, benztropine, amantadine. Tardive dyskinesia, TD. Irregular perioral movement. Darting/protruding tongue. Tics. Irregular blinking. Swaying. Best management for TD, lowest dose of antipsychotic. Metabolic symptoms, increased BP, BG, obesity, weight gain, abnormal cholesterol level. Olanzapine/clozapine, highest risk of metabolic symptoms. Clozapine, agranulocytes are a type of white blood cell, leukocyte, characterized by the absence of visible granules in their cytoplasm. Highest risk of hyperprolactinemia. Paliperidone. Risperidone. Ziprasidone. Hyperprolactinemia. Both typical and atypical. Male, large breast, erectile dysfunction. Female, irregular or absence menstrual cycle, milky discharge, excessive body or facial hair. Both loss of interest in sexual activity. Risk increases with strongly blocked dopamine, paliperidone the most. Antipsychotic black box warning, heart failure, infection, cause pneumonia. Neuroleptic malignant syndrome, rare but life-threatening. 1. Altered mental status. 2. Rigidity, lead pipe. 3. Hyperthermia. 4. Autonomic instability, tachycardia, tachypnea, high or low blood pressure. Action, hold medication and call MD. Risk factor, dehydration, history of NMS, recent dose increase. Psychomotor agitation. Early sign, low-grade fever, tachycardia, increased blood pressure, catatonia, diaphoresis. Nursing intervention of NMS. 1. Stop antipsychotic immediately. 2. Call MD. 3. Monitor VS, hydration to flush out, reduce fever, ICU/ventilator as needed. 4. Med, heparin prevent clotting, dantrolene for severe rigidity, bromocriptine for stimulate dopamine production. Benzodiazepine, for those don't respond treatment. Serotonin syndrome, caused by high level of serotonin. Happen with MAOs, SSRIs, TCAs. Symptom: severe hyperthermia, confusion, rigidity, respiratory failure, coma, death. Clozapine, olanzapine, and ziprasidone may cause hypertensive crisis which characterized by severe headache, chest pain, shortness of breath, changes in vision, confusion, and nausea or vomiting. Short-acting IM injection, used for rapid tranquilization. 1. IM cocktail, haloperidol, Haldol, lorazepam, Ativan, diphenhydramine, Benadryl. They can't be the same syringe, it will always be 2 shots. 2. Chlorpromazine, Thorazine. 3. Olanzapine, Zyprexa. It can last for 1 month. Clozapine nursing intervention. 1. Need blood draw routinely. 2. Abrupt D/C will cause cholinergic rebound, acute psychosis. 3. More seizure, new seizure plus dehydration, best choice. Blood drug weekly 6 month, then 2 weeks 6 month, checking for ANC count. Short-acting IM injection, used for rapid tranquilization. 1. IM cocktail, haloperidol, Haldol, lorazepam, Ativan, diphenhydramine, Benadryl. They can't be the same syringe, it will always be 2 shots. 2. Chlorpromazine, Thorazine. 3. Olanzapine, Zyprexa. It can last for 1 month. Clozapine nursing intervention. 1. Need blood draw routinely. 2. Abrupt D/C will cause cholinergic rebound, acute psychosis. 3. More seizure, new seizure plus dehydration, best choice. Blood drug weekly 6 month, then 2 weeks 6 month, checking for ANC count. Echolalia, learning what nurse saying. Echopraxia, learning the action. Anergia, no energy, passive, lack of persistence. Anhedonia, inability to feel pleasure. Avolition, lack of motivation, inability to complete tasks, like ADL. Antidote for benzodiazepine, flumazenol. Anticholinergic crisis, life-threatening condition, overdose or sensitivity to drug with anticholinergic property. Sign and symptom: hot as hair, blind as bat, mad as hatter, dry as a bone. Usually, 3 days after drug discontinued. Treatment: discontinue the meds, physostigmine, gastric lavage, charcoal, catharsis, for intentional overdose. Echolalia, learning what nurse saying. Echopraxia, learning the action. Anergia, no energy, passive, lack of persistence. Anhedonia, inability to feel pleasure. Avolition, lack of motivation, inability to complete tasks, like ADL. Antidote for benzodiazepine, flumazenol.